Just give me the link and then I will send an email. Is the second one the final link?
The second link on the chat is the one that's working now. So
okay. So can I ask for Mustafa to add it to the Facebook, please? I have seen you here. Or Mercy, the other ambassadors, Celestine, please add the link to the Facebook, the new link, as we need it. Hi, Roger.
Okay. So that's the second link, not the first.
Yes, hello.
Yeah, yeah, the second link, Mustafa. Yes. We are just starting the tech things, but we will be starting in a minute, 2 minutes.
Yeah,
yeah.
Okay.
Okay. Can anyone check if the YouTube link is now this second one working?
Second one is working.
It is? Okay. I will just email everybody because they will be waiting us on the first link that I sent by email. They are actually waiting there. Can you send a message on YouTube that we changed the link? And add the new link?
Okay, 2 seconds.
Sorry, what did you say? The South African time is 2:30, but the international time is 2 o'clock.
Sorry, what it says is it's 1:30 p.m. And then you
add 2 hours to get the international time. Okay.
2 hours.
Yeah. So then you put it on. No, it's UTC plus 2, so wouldn't it be 11 on the universal time?
And we're just showing it on YouTube. We're just sorting it out.
Okay.
Not on day one.
Since day one.
It reminds me of the time when I went to meet my wife at the Royal Albert Hall for a concert.
I've shared the link on the Facebook page.
Perfect. Thank you. I think I have sent the email now. I think we are ready to start. Can I, we are not seeing the venue at South Africa. I think the camera closed, but we will start. Is everybody ready? Can I ask you for everybody to open your cameras? As we are doing a rural cafe. We are about to start in 2 minutes. I think we'll give 2 minutes for everybody to be completely ready and those that want to enter. And yeah, in about a minute. Please get your coffee or your tea or whatever you want to drink with us today. Very good, Ian. Perfect. Perfect.
I would happily have some mate if I had some with me.
I have my mate here.
Good, enjoy.
Okay. 1 minute and we will start. Just keep asking for people to open their cameras. Staff as well, our new ambassador. Here we go. Okay, we're going to start our rural cafe. Is that okay, Steph? And the people back on South Africa? We are not seeing you, but I'm not sure if you can listen myself.
We can hear you clearly.
Yeah,
but I don't know where they are in the room.
Yeah.
There they are.
Yeah, okay. Okay, so good morning, all from Brazil. Here's Mayra Flores speaking. I was introduced earlier into the conference, but I will just present myself saying that I'm a family doctor from Brazil, which I will ask for people to introduce themselves as well, saying who they are and where they are from, and just like the first job, not a very long presentation, so we could move further. This is a rural cafe, a special edition with the Rudaze conference, the Rural Health Conference in South Africa. We have a really, really great group of people here, and I'm really excited to talk. I do want really to welcome the new ambassadors from Africa, Mercy, Mustafa, and Celestine. I think we are like doing a very beautiful transition, and I'm really excited for discuss about why rural, why we decided to go rural, be rural, and like a little bit of the problems, but also the hope and what we expect. We would have a Mustafa, Mercy, and Celestine also bringing the questions from YouTube and from the Facebook link. So I think it will be a very, very cool moment this morning. And I'm so sorry that we got a little bit late, but everything's sorted and it will be very good. I will give the microphone to the next person, and I will be calling you one by one, so you can introduce yourself and talk a little bit about you. So Adam, can you introduce yourself and say what you're going to drink during this presentation?
Good afternoon, everyone. My name is Adam Askar. I'm a family medicine registrar at the University of KwaZulu-Natal, which is in South Africa. I'm one of the Rural Health Conference. I'm one of the members of the organizing committee of this conference, and it's a real privilege to take part in my first rural cafe. My heart is in rural, if I can put it that way, but most recently I've been working in an urban environment over the past 2.5 years or so. So this conference and other such interactions are my only way of getting my rural fix at the moment. I'm drinking just a regular black coffee.
Oh, it's the idea to have coffee or whatever. Can I ask for Batembu I'm not sure if I'm pronouncing your name correctly, but correct myself, please. Can I just remember that we are also on Facebook? And so please, I will ask for commenting there, commenting on YouTube, and you can also use the hashtag Rural Cafe on Twitter. Batembu, it's with you.
Greetings, everyone. I hope you can hear me.
Yes.
My name is Batemu. It's actually pronounced Batemu, but you get there. My name is Batemu Kujo. I'm a fourth-year medical student at the University of the Witwatersrand, University in Joburg. I'm also the chairperson of the Wits Rural Health Club, which is a club that is aiming to increase awareness and aim to try to help in improving the quality of health in rural areas. So yeah, so why rural? I come from Eastern Cape, where a huge percentage of one of the provinces here in South Africa, where a huge percentage of people reside in rural, and I've been exposed my whole life to the not so good quality of healthcare in rural areas, or in hospitals that supply that service people from rural areas. So yeah, unfortunately, I'm not drinking anything. So
not a problem at all. You can just have a chat. Good to have you. Mustafa, can you introduce yourself?
Hello, everyone. I am Mustafa. I am a fifth-year medical student from Nigeria, and I am the Rural Seats Deputy for Africa. It's nice to meet you all here, and I look forward to a good interaction. Thank you.
Thank you. Ian, you're the next one.
Thanks, Mara, and hello, everyone. I'm Ian Cooper from Ukwanda Centre for Rural Health, Stellenbosch University in Cape Town, South Africa. But I'm coming to you from the game reserve, where I'm with my family on a multiple birthday celebration that was postponed because of COVID lockdown in July. So it should have happened then, and I should have been with you face to face, but it's good to be able to connect, and I'm drinking coffee with milk. I should have said I'm also part of the Wonka Working Party, and Mayara and I have connected over some time.
Sure. Thank you, Ian. Mercy, you are the next one.
Good afternoon, everyone from Kenya. I'm Mercy Wanjala. I'm a family medicine resident at the University of Havana, Cuba. I'm currently doing my third year surgical rotations in Kenya. And I'm very happy to be part of this discussion today, Why Rural? And I'll be bringing you the comments and questions from Facebook. Thank you, Maya.
Thank you so much. Roger, you're the next one. Roger is the person that is with myself since the first Rural Cafe.
Yes, hello everyone. My name is Roger Strasser. My background is as a rural general practitioner, family physician, originally in Australia and then in Canada. And now I'm speaking to you from New Zealand, where I'm the professor of rural health at the University of Waikato in New Zealand. And as Mayara said, I'm was part of the first Rural Cafe and many of them since. And so it's wonderful to be with you today. I actually am drinking water with a bit of slice of lemon in it, largely because it's almost midnight here. So I don't think coffee would be a good idea because I am looking forward to sleeping.
Absolutely, Roger, you're right. Bernhard?
Hello, everyone. So I'm Bernhard Gede. I also worked as a rural doctor for many years, but now I'm at the University of KwaZulu-Natal here in Durban in South Africa. I'm in family medicine. And yeah, I was running the rural cafes at previous Rudasta conferences. So kind of they were all in-person rural cafes. So that was really special. So it's great to have an online or participate in this online version now. And I'm drinking water.
Perfect. Thank you so much, Bernhard. I'm not sure if you pronounce it correctly, but you can correctly. It's Vularli, or I'm sorry.
It's okay. It's Vutlari.
Okay.
Yes, Vutlari. So hi everyone, my name is Vutlari Shirinza. I'm a fourth year medical student from the University of Cape Town, South Africa. And I'm also the deputy chairperson of our Rural Support Network, which is a student-run organization that advocates for rural healthcare for students. So we operate at a student level, and I'm also the student representative of RUDASA. And I'm very happy to be at my first Rural Cafe and very happy to be joining the call with so many phenomenal people today.
It's really good to have you on board as well. Carissa, God,
Hi,
I'm sorry about the names, but if I pronounce it wrongly, you correct me.
It's really not a problem. My name is Caressa Govender, so close enough. I work for the Rural Health Advocacy Project, specifically on human resources for health, but I'm also an occupational therapist. This is actually my first Rural Cafe, so I'm quite excited about it. And yeah, that's it from me.
Thank you. Fatum?
Hi all, my name is Fatuma Lo and I am a final year medical student at the University of the Witwatersrand in Johannesburg, South Africa. I am also student representative of RUDASA, which is the Rural Doctors Association of Africa with Vutlari Shirinza. And I was previously on the committee of the Wits Rural Health Club. Also excited to be meeting you all and looking forward to an amazing discussion.
Thank you so much. Eunice? Not sure.
Hi everyone, my name is Eunice Monzo. I work for the Rural Health Advocacy Project in the HRH team with Carissa Govender. This is actually my first rural conference and my first rural cafe. So I'm really excited to be part of this discussion and just to hear from different people.
Thank you. And Celestine?
Hi, everyone. Hi, can you hear me?
Yes.
Yes, thank you. My name is Celestine Todosia. I am a nurse, actually, just completing my nurse internship here in Kenya. And I am a member of the Rural Health. I am the ambassador, deputy ambassador, African region. I'm so excited to be part of this team, and I would love to welcome all of you to be part of this meeting. We've had previous meetings, and they have been very, very fruitful. I look forward to discussing more with you people. Thank you.
Thank you so much. So we have a little bit, I really wanted to ask for those that are at the venue, if you can introduce yourselves on the YouTube so we can read who you are, or you can also introduce yourselves on the Facebook. Or will you introduce yourselves okay, very quick.
So I think it might be easier. There's very few of us, not very few, there's a few of us here, but not too many. So my name is James Zadenhurt, and I am an experienced rural doctor. I spent almost 7 years working in Northern KwaZulu-Natal in South Africa. I have, however, moved on, and I'm about to start a master's through the London School of Hygiene and Tropical Medicine, focused on clinical trials. Thankfully, it's distance learning, so I don't have to worry about travel restrictions, and I am drinking Sprite.
Cool. Please talk very close to the microphone because we have like some echo.
I'm Herman Reuter. I'm a doctor and I help people with substance use disorder, mainly in George, Google district in the Western Cape of South Africa.
Cool.
I don't drink any alcohol.
Okay.
Hi, I'm May. I'm a medical doctor who did a concert at Rural Hospital in Malanga, South Africa.
and I just have a passion for community health and rural healthcare. I am drinking water.
Perfect.
Hello, I'm Emily. I'm a doctor working in rural Malacca. My kind of area of interest is especially rural obstetrics. I'm not drinking anything right now, so I'm not very much.
Okay. So, there's more people. Sorry, I wasn't seeing.
Yeah, it's the camera lens is not quite
Okay.
I'm Dr. Madeleine Muller. I'm a family physician out in the Eastern Cape. Currently working in the family medicine department, but also with senior lecturer with WUSU, special interest in RHC in terms of mentoring and supporting mentoring in South Africa.
Good to see you. Is there more people? Okay.
And I'm at the end of the list. Yeah, it's Victor Fredland. I've actually just retired, but I'm still involved in rural healthcare. I was working for 40 years at Umseleni Hospital in the northern KwaZulu-Natal.
Great. Good to see you all. We have many people that retired. I started to think that you can left rural in some way, like to left your rural practice, but your rural practice will never left you from your heart and your mind, and maybe that's my impression at least. So why are we here discussing about rural health? Like, what made you to decide to be a rural doctor? I will ask for like people to put your hands up for those that want to talk. It could be on the Zoom thing here, or just put your hands up. So why have you decided? I will start by my own story. I had the chance to experience a little bit of rural in Ireland, and then I got passionate about it. So that was how I decided to be a rural doctor. But why are you here, and the students, like, what makes you think that rural is a good idea, and why have you decided to think about rural? So, the roof. Anyone wants to start? Everybody really quiet. Roger, can you start?
Yeah, absolutely. So I guess I found my way into rural practice really because my mother had been a teacher in rural high schools, and during the long summer holidays, we would go and stay with friends on farms, and I kind of got a taste of rural living then. And as I was doing my medical education, I took opportunities to do electives and get experience in rural settings. And after I graduated, I was initially thinking in another direction, but once again, I was drawn to rural, and I think to family medicine general practice because it's about relationships, it's about people. And that's what's so rich and rewarding. And in the rural setting, you're very much part of the community. So it's getting to know people and having long-term relationships with people, not only as patients, but also community members, and involved in social and recreational activities in the community. And so that's what I find so rich and rewarding about rural practice.
Thank you, Roger. I will ask for Bernhard, because you are the person that have done the cafes before.
Yeah, great. So my journey, I think it kind of echoes a little bit what Roger was saying. I was also kind of started to get quite interested in rural health while studying. I did some electives and visited a few people in rural areas while studying. I also had quite a long connection. My grandmother was actually a mission doctor who worked in a small rural hospital. So kind of there was like quite a long family history about that. And again, it echoes very strongly what Roger was saying, that in rural medicine and working in a rural area, you are much more connected into the community. Like you you much closer to the context that people are in, and kind of and I really enjoyed that a lot. I mean, that made it kind of much more immediate, and those relationships, like it kind of over a longer period of time, it's much like it seems like completely intrinsic to how kind of a good rural practice functions. So yeah, I really enjoyed that, and even now I've left like the Emmaus Hospital where I was working for quite a few years, about 10 years ago already, which I can't believe. But you're absolutely right. Like, it hasn't left me at all. I still go and visit, and even I mean, just the other day, we send students to the hospital, and just the other day when you walk in, there are a whole lot of people that you still remember, and it's like a big hello and like an absolutely amazing reconnection. And I mean, these connections just seem to carry on and carry on. It's really amazing.
Ian?
Yeah, I think it's a complex question or a complex answer. I don't think it's one simple thing, and I think research we've done confirms that there are multiple things. But for me, I decided to do medicine. I was training to be a psychologist, decided to do medicine because I wanted to make a difference to people who were in need and people who were poor, both at an individual level and a community level. That was in the 80s in South Africa under apartheid. It was very difficult to find ways of doing that. And one of the ways to do it was to go rural and work in rural communities. And I realized that one could make a difference to the inequity. And in some ways, apartheid at one level continues in South Africa because that inequity continues for rural communities. And so it's a lifelong work. And I also want to say that it's thanks to the Wonka Working Party in rural practice, and specifically to Roger, that I also was able to see the vision that rural health can also be an academic discipline, that it's not just a clinical discipline. And I was able to explore that and build on that. And my experience of working for 6 months at the Monash University Centre for Rural Health is something that's also helped me as I now am leading a Centre for Rural Health at Stellenbosch University myself. So, I mean, I think the international connections, as much as the local community connections, are also things that have driven and supported me in this journey. Thanks.
Thank you, Ian. I didn't know many things that you said today. That's really great. We are always learning about each other. Can I just welcome Zakir Lungil that just arrived. Zakir, can you introduce yourself very briefly and Lungil, so we can go back to our first question.
Hello, good evening from Bangladesh. This is Dr. Zakir Rahman. I'm working in a rural setup. So, very happy to be continue with you. Thanks, Maya and all. I say Roger and Ian there. So my story is we have more than 80% people are lived in rural areas. So when I was in medical student, so I believe to serve most of the people or rural is choice, and that in rural conference I confined, and I'm very inspired to continue work in rural areas. So many rural workers, those who are working in rural, I just follow them and inspired by them. Myra.
Thank you, Zakir. Lungil, can you introduce yourself? Yeah.
Can you hear me?
Yes.
Okay. I wanted to share why I ended up in rural practice. So in my very first year as a medical student, I was part of a Christian organization that a few of us went to Mozambique to quite a rural area in Mozambique where there was a clinic running, and it was amazing. That experience for me as a student was amazing to, yeah, really be able to connect with people. And then in my final year, I was already interested in rural by that stage, but I spent 2 weeks at a rural hospital, and I really felt part of the team very quickly, where in my curriculum, I hadn't felt so welcome in the other environments in internal medicine, and yeah, you felt a bit more like a nuisance as a student, but yeah, I felt very useful. And so I also was very interested in the lifestyle. So the hospital that I was interested in, Sedegi Hospital, had scuba diving and game reserves and all kinds of possibilities to travel to nearby Swaziland and Mozambique. And so for me, I did really enjoy the work, but I have to say the lifestyle was very attractive to me.
Thank you. Adam, I think you also have a really good story to share about why you decided to be rural. And I want the students also after you to talk.
Well, thanks, Mayara. I probably feel a bit shyer sharing my story in front of 20, 30 people, but here goes. It's easier one-on-one. I think my journey to rural started off as some sort of misguided youthful ambition that I felt I could, you know, be some sort of medical hero in a rural setting. And obviously, as time has gone on and I've become a bit more humble and realistic, I think the things that drive me forward are very different to those initial youthful, misguided aspirations. But I think the things that keep me wanting to return to rural are the connections that the other people mentioned. I find that working in an urban environment, even at district level, which is, I guess, the closest chance I usually get to work in a primary care setting as a doctor, even at district level in an urban environment, I end up feeling much more like a technician than a human doctor sitting in front of a human person who happens to be a patient. Yeah, so that's I guess why rural for me.
Perfect. I think this humanization perspective isn't like to be a human in this world as well. Very good. I will ask for Futuma. Can you tell us why rural?
So I'm based at Wits University, which is a very urban university in Johannesburg. And as much as, you know, they always try to include lectures about rural health, it's quite minimal compared to the rest of the curriculum. And it's often as a side thing, it's not really the focus. And, you know, as students, we don't really know what to expect because our teaching grounds are predominantly these tertiary hospitals, these district hospitals. So when it comes to selecting sites for your future internship, you know, it's much easier to gravitate towards something that you know and are familiar with, not necessarily because we do not want to work in rural, but you don't really know what to expect and you just hear stories and you don't really know what to go by. So we know that considering the demographics of South Africa, as mentioned by Prof. Cooper, and the equity and healthcare demands of this country, we know that a lot is lacking in terms of our rural settings. And as students that are future healthcare professionals, if we do not want to go to these settings, how do we expect to see the change? So I think it's just, you know, really being the change that you want to see in future and just advocating and hoping that you inspire your fellow students to follow your route. So yeah, that's why rural for me.
Really powerful. And it kind of resonates when I was a medical student. When we started the Rural Cafe, we started as a medical student, and then I think Ian and Roger mostly have seen us, myself and others like Amber, to grow in this way, getting the graduation and then getting the residency and keep going. But it seems the same in Brazil. We have the same issues, like it was never mentioned in my graduation about rural. And then we need to bring them into the grad, but the undergrad, but it's still a very, very challenging. And as one of the things that made us to create the Rural Cafe and even rural seats, to try to make it more achievable, to make it more accessible for students, because people are not even exposed to it. It doesn't, people doesn't even see it. Can I ask you, Vucharli? I'm sorry, it's very hard, but I will learn.
Vucharli, but you're almost there.
Okay.
Yeah, so I think it echoes a lot of what Futuma said. I think especially as a student at the University of Cape Town, we have very little, if any, exposure to rural. So far in my curriculum, I haven't even heard the word rural come up, and this is like my 4th year. So as the Rural Support Network, we honestly are the only exposure that students have for working in rural. And through the program, through the organization, I got to spend 2 weeks in Kanzibe in Eastern Cape when I was doing my 2nd year. And it honestly was the best time that I had in my entire years of study, because like Jane said, I felt you feel welcome as a student. You feel wanted, you feel accepted, you feel valued as well. You're not just like another fly on the wall, you're part of the system as well. But I think more to what Adam mentioned, you really feel like you're contributing to people's lives. Like when you speak to a patient, it's like you're speaking to the whole community just through that one person, because they hear you and they really value what you're saying. But I think why rural for me personally is because my family is also from rural Limpopo and rural Mpumalanga. And, you see how healthcare is for them, because they mostly access it through the public system. And you realize how it's just dismal and there's so many things that need to be changed about it. But the change isn't going to happen if it doesn't happen through health professionals and competent doctors that are working there and are passionate about the jobs that they're doing. And especially young people like us who need to go and work there. So as Fatuma mentioned, like if you're taught in a tertiary system, you're most likely going to end up working there as well. So it's very ironic for us to say, no, the public system needs to change, but we're not the ones going to be going there to change it. So I think rural for me, because I actually want to be part of that generation that changes South Africa's healthcare system and changes rural, and just get more people to go towards rural and to see how amazing that lifestyle can be.
Wonderful, thank you so much. I think Mustafa, Mercy, and Celestine can help you like through rural seeds, and then help the students here to like do what you're proposing and support you on this way, because we are all like in the same boat, or at least in the same sea. I will just bring some things from Twitter, and then we can go maybe to Carissa, Mustafa, and Mercy, and then move a little bit on into the discussion in Celestine. And if anyone wants to talk, please add on the chat for those that are in here, so I can like create an order, so it will be easier to flow into that, like Mustafa or Mercy, if we can create like, tell me who wants to talk so I can know it. But one thing that I want to mention is that we cannot discover rural by accident, like was for myself, or even for Futuma, or from Pucharhi. It couldn't be by accident. It should be mentioned from even the first day. I really want that after Roger talks a little bit about having it into the education, but I will also ask before that, I'm not sure if I will pronounce it correctly, but Mapuche to introduce herself because she didn't introduce herself yet.
Hello, my name is Maputi. I work in Jubilee, which is in Gauteng. It's a district hospital, so it's not really rural, but it's peri-urban. But I grew up in a village in Polokwane, which is in Limpopo, and yeah, I basically grew up there for a very long time. So why rural for me? When I was after high school, I struggled financially, and I got a scholarship to Cuba. So for the 6 years that I was in Cuba, I saw how family physicians were the pillar of the community. Yes, there are specialized hospitals, but those people don't interact with the community. And I saw how long the people there lived. I saw that in the community. I stayed in Santa Clara, and like 80% of the population was over 75 years old. And at home in Polokwane, people are just dying like flies. But I thought that Cuba was too small, and it's like one province in South Africa. So I thought that what was happening there would not be applicable to South Africa. Then I went to Stellenbosch. I remember the first day we went there in the Western Cape. Maya, you may not know where Stellenbosch is, perhaps, I don't know, but it's in the Western Cape. It's another province of South Africa. It's one of those well-off provinces, if I should put it like that. It's not very, very rural, but there are rural parts there as well. So when I was there, they introduced us and they were like, we actually have a rural center, you know, in primary health called Ukwanda. And I was like, yeah, no. What was happening in Cuba would not be applicable in South Africa. But then the people, the facilitators in the Ukwanda program, they took us to Australian Dam, to Ceres, to what they were doing, the kind of primary healthcare, rural healthcare that they were providing. And that opened my eyes a bit, and it lit a fire in me. And I thought, maybe this could be done, you see? And then as I was rotating in other hospitals, like I went to Nelspruit, I was in Rob Ferreira. Then I went to a very, very rural town called Palale. I could see that if we could do something, you know, as family physicians, if we could just engage and be involved the way they were in Ceres, in Solendam, that side, perhaps we could do something, you know? Perhaps it's not about, you know, the resources from the government only, but about the human resources as well, you see? And being a village girl who likes small towns, family medicine looked like where I belonged. That's why I'm specializing in it now. I'm doing my 3rd year, and I hope to be a family physician who's going to be based in a rural facility. Thank you.
Wonderful, thank you. I think you have answered also our question about why rural. I just need to say that Zakir leave us because he had an emergency, so that's okay. Really, really great. I will ask for Carissa for her saying why rural, and yeah.
So yeah, I think my experience is very different from a lot of the others in the room. So I actually haven't practiced in a rural area. And during my undergraduate studies, my rural exposure was limited to about, I think, 3 weeks in my final year, which in retrospect did not completely change my perspectives of rural at the time. You know, it was kind of considered an easier kind of block to pass. But so I kind of feel like I fell into the organization that I did somehow. But what I really do value about rural health is kind of the interconnectedness and the interreliance of health professionals on each other, which I can't say I've really experienced too much working in urban facilities. And there's this sense of agency where it's not just about saying, well, the government is not doing enough, but that people are actually able to make it work just by having those communities of practice. And I think it's also something that kind of comes up repeatedly through the Rural Health Conference every year. So no, I didn't work in rural. I stumbled into rural health, but yeah, loving it.
Perfect. But it kind of has something that connects, like that make you feel interested, and then you see that's about justice and equity and everything. I kind of feel it. Mercy.
Yes, thank you, Maya. I'd just like to read out a comment, post from Siarhan. He's not said where he's from, but he says, being a rural worker is my passion and a personal and social responsibility to meet the needs of patients and rural society for equitable health.
Perfect. Can I just say that for those that at the venue, if you want to talk, remember to put your hands up so I can identify you, and then you can talk. I can call you. Mustafa, can you tell why rural?
Oh, thank you very much, Mariam. For me, really, it's from my first year in medical school. So I learned about the primary healthcare system more, and I wanted to know really what's the situation on ground like. I think this might be better. So I wanted to experience what the primary health centers are like in reality, not in the books. So I had an internship with the Ministry of Health in my state, and we visited the primary healthcare centers for quality assurance. And I was very surprised what I found. Out of my team, I visited about 11 or 12 primary health centers. And out of that, I think only one had a doctor. And it was really bad. Most of them, it was the nurses and the community health workers. And even that, not all of them have those, because those primary health centers were within urban regions. So I was wondering how it will actually be in rural areas. So added to the fact that yearly we carry out outreaches to rural communities from our medical student association as well. So when we go there, we see typically 1,500, 2,000 or 3,000 patients coming. Although we are just students, we assess them basically for hypertension, diabetes, and basic medications at the primary health center level. So it's surprising to see that this much people wait for these opportunities to come to seek for help, and really in terms of the reach of health services to these rural communities is very, very low. So that is my passion really. How do we increase access to healthcare in these rural communities? How do we ensure that round the clock, all through the year, they have access at least to the basic needs of health? They don't have to wait until there's an outreach, or they mostly go for traditional medication. And some of them are not really verified, and they end up with complications from that. So yeah, that's really my passion. Thank you, Mayara.
Beautiful. We do have, I think, Lungi and Evelyn at the venue. Lungi, are you going to, I haven't seen you yet. Or Lungi at the venue. It's both things, both person are in the venue. So sorry, Lungi. So you and after Evelyn.
Great. Good afternoon, everyone.
Please a bit closer to the microphone and very loud so we can hear you. Okay.
Good afternoon, everyone. So I'm Lungi Hobe. I work in Mseleni Hospital, which is an area where I was born. I think a few people have heard my story already on why rural for me. So we Mseleni Hospital is basically the only hospital in the area. And with my family living there, my one question is always, what will happen if a member of my family collapsed at home? The nearest private hospital is about 150 kilometers away. So my thing is we need to improve the quality of care within the hospitals that serve our communities. So I heard Adam earlier saying that it was probably a little bit of a heroic thought to say that to think that he could change rural healthcare. I still strongly believe that with the right policies, systems, human resource, and a few other things, we can actually get quality medical care to our rural and remote areas. So I have stayed on because I still believe that there's still more to be done within that hospital. Thank you.
Hi, I'm Emily. So for me, I was first exposed to rural health when I did my student elective in my 4th year at one of the centers of excellence in the Eastern Cape. And I saw what rural healthcare can actually look like when the team works really well together. And I think rather naively, I thought I could replicate that in my community service here at a different hospital. But since then, I faced a lot of challenges, but I've also, what's kept me in rural is the ability as a rural and a junior doctor. You actually have a lot of responsibility in the rural setting compared to an urban setting where you have a lot of support. And one of the positive things about that is that you have a lot of opportunities to do quality improvement. So it's really rewarding being able to see things that you implement and to see how that impacts the community and your patients. So the other thing that has kept me in rural is just knowing the need is so great compared to, I think it's similar across the world where the majority of doctors go to urban areas and actually look after a very small proportion of patients in the country, where a lot of patients have many smaller number of doctors looking after them in the rural setting. So yeah, that's what also keeps me going to motivate me through those challenging times.
Thank you. That was very, very helpful. I think we are seeing a little bit flying into the dam of the rural, isn't it? And if you go to the evidence that we have, we certainly see that all these reasons that you are mentioning here, having a rural background, having exposure into education, being an experience in the that you feel part of the community, as Roger said earlier, this change how we see rural, and this change and then this make us to decide to go rural. So that's really interesting. I will bring some people are tweeting, and I'm covering the tweet. So we have Mayday that just, I'm not sure if she's on the venue, but she added about the rural cafe, and oh yeah, cool. And we do have people talking about the urgency of having rural into the graduation, and also to be experiencing a rural cafe. Really cool. Can I ask, we do have some people that haven't talked yet. Can I ask, we do have maybe Mercy want to talk again, and then Celestine, and I'm a little bit lost of who haven't talked and not. So if you can turn your hand up so I know if you talked or not. Mercy, and after Celestine, and then I think it could be more flowing. You can just turn your hand up, and then we can keep talking. Mercy.
Thank you, Mayara. I think for me, what I landed in rural practice more by, I stumbled upon it more than by intention, because after my internship year back in 2015, I was posted to a rural health center. So when I got there, the initial plan was to just pass the time there as I plan to go back for my postgraduate studies. But when I got there, the situation there was so horrible. I just realized I had to stay, because even the experience from my first day, you meet patients who've never even seen a doctor or heard of a doctor. The only people who are covering rural facilities at that point were nurses. Many doctors didn't want to work in the rural areas. They'd get posted there. After 1 or 2 months, they'd leave. And that was what I was planning to do myself, because I was born in the urban area, lived there, so I was used to that life. I didn't want to go and work in the rural area. But after staying there and seeing the dire situation there, I decided to stay, and I kept on staying. Even after that, the next facility I worked in was still far-flung in a rural area, but I stayed, not because it was easy or liked the lifestyle. I didn't like it at all, but I just stayed because the people there needed help. So mine is more of a story of a bleeding heart. And then afterwards, I was actually supposed to go into psychiatry for my postgraduate, but seeing the kind of a situation, the healthcare situation that we have in rural areas in Kenya, I decided to go and do family medicine so that I can focus on primary care, because the truth is we cannot speak about UHC, we cannot speak about quality healthcare for all, and then ignore the people who live in rural areas. And in Kenya, it's 80% of the population. So for us to do anything about UHC, for us to talk about healthcare for all, we have to go and make sure that people in the rural areas get what they need. Thank you, Mayor.
Very, very touching, Mercy, really. Thank you. I should thank you, Celestine, for, I should thank you for deciding to stay, isn't? I think everybody should like thank you each other to decide to stay and for us to be working with rural. Celestine.
Hello.
Hello.
My name is Celestine Todosia. I am a nurse. I just say that I'm almost completing my internship. So rural health, I'll talk about it. It's from more of a personal experience. I grew up in a rural setting of Kenya. So most of our health services, we got it in the rural setting, and we got them from nurses, because there were basically no enough doctors to come into the rural setting. So I imagine if we didn't have them coming to the villages, we wouldn't even have the basic services like vaccination. That would be a dire situation. So I was motivated to work in those areas so that I can provide the basic needs of health, because there's no one to come in there. So recently I've bumped into an organization called Dealing with the Key Population, that is people living with HIV/AIDS. And we've noticed that most of them do not come to the health centers that are situated in the urban setting, because most of them do not have enough money to come there. The places are far. So we decided to go there. Sometimes we let our clients come to us, but we said as health workers, let's go to our clients. So we decided to be going to the hotspots to provide the healthcare services. And we've noticed that over the time, we've had a very good data of viral suppression going down, because people are now taking their medication because we are going there. And we are happy about that. So out of that, the small services that we're giving, like just refilling the medication and talking to them about this disease and health education in general, it has given a very big impact to them. And I always ask myself the question, what if we increased our rural health system more strongly? What will happen? So it is going to be, I'm sure it will be a big impact. And I also I happened to practice in a big hospital. I trained in Kenyatta National Hospital. That's the National Referral Hospital in Kenya. And I've seen a long list of people coming to get procedures, major procedures from there. So you book your surgery in January and you get it in October. And for some diseases that are progressive, like the cancerous diseases, then you wouldn't have saved that person. So I was thinking, what if we those services, we took them to the rural centers, then we'll be helping them a lot. So that's one of the motivations that keeps me going and advocating for rural health. Yes, thank you.
Wonderful, Celestine. And we do have Batimbu, I think, haven't talked. Have you talked? I'm not sure. And maybe we can think a little bit after. I will invite Roger and maybe Ian to talk a little bit about this, what we have been talking.
Oh, I'd like to first apologize because I was having issues with my laptop, but I think they fixed now. So on the question of why rural, I mentioned it earlier that, okay, so I did not specifically grow in a rural environment, grew up in a township, but then I was exposed because I do have villages, rural homes, and then I was exposed in someone mentioned that the accessibility to the hospital, you find that the nearest hospital from where I come from is like 30 kilometers away. So, and it becomes a problem now to access the hospital for some people, because some people don't even have access to cars. So they have to call, if someone mentions something, if you have an emergency, like even let's say during the night, you have an emergency, some people have to knock on neighbors' houses asking for someone with a car to transport the person to the hospital. And even then you have to hope it's not raining, because the roads also are underdeveloped. So if it's raining, it's gonna be a tough time. So yeah, it's that accessibility that actually pardon me for the noise, that actually motivated me to look into it. Like, how do we how do we cut down that bridge between hospital and the people? Because I think it was Dr. Mercy who said it, that there are many situations that are affected, and rural people people who are residing in rural areas, they're often neglected. So that is something that I felt like I should embark on. And also, I also relate from a personal perspective, because my grandfather, he had passed away when I was 14 or 15, I don't remember. And it was what occurred to me, because he was at a rural hospital, and what occurred to me was that he was not attended to on the day he passed. So that was something for me. It was like, I actually want to do something to help change the quality of healthcare in a rural setting.
Perfect, thank you. Can I ask you, we do have Victor and May at the venue.
Hello. Why rural? Well, you know, I think we all have reasons why we get started. And I think probably, I would say the reason that I went rural is I wanted the best thing in life. I wanted to do what God wanted me to do in life, so that I might receive his blessings. And I think it is more blessed to give than receive. Acquisition is not the best thing in life. It doesn't make life the best thing for you either. I have received tremendously. And I often thought to myself, when people said, oh, you're in a rural place, that's a terrible sacrifice. And that's a common theme that people bring in. And I thought, if they only knew what fun I have, if they only knew how enjoyable it is to work with people. Yeah, there are struggles. But if they knew how much fun I was having, they would, you know, withdraw their sympathy, I think. And I'm sure that's our experience as we work in rural. I think I stayed in rural. Each day was a challenge, but the challenge was part of the enjoyment. The challenge was part of going on, moving forward, seeing greater opportunities, the opportunity to make a difference in people's lives, the opportunity to help people who had less than you had in some way. They were needing healthcare, to be able to share with them. to see people like Lungi grow up and become the medical manager of the hospital. You know, what more do you want in your career? I mean, you could drive a Rolls Royce, you could, sit beside a big swimming pool, and you'd be totally bored and really have nothing left at the end. So I think rural offers a tremendous diversity. I would get him in the morning and I could resuscitate a little baby. I could do an ultrasound on a pregnant woman. I could do a Caesar. I could give an anesthetic. I could replace a hip. I could deal with someone with a stabbed abdomen. I could treat somebody with TB and then go home for tea. What other job can you do that? Where else can you have that range of option? I mean, I did a little locum in the UK. I think it was in general medicine. I was in the outpatients. I wanted to have the patient. I wanted to do an ultrasound of the patient. No, you can't touch the ultrasound machine. That has to go to the ultrasonography. You can't look for the cardiac problem. Everybody was in the little box. But the whole thing was just open for me. And I could explore all the little components. And I could do water systems in the community. I could develop a clinic. I could build VIP toilets. Yeah, sometimes be involved in exhumations, which is maybe not so much fun. But the range is enormous. And why do you want to restrict yourself?
Perfect. I think people are clapping the hands. And actually, Carissa just put on the chat here that she hope or wonder if the question will change to why urban, isn't like in the future. So we have a long work into thinking on education, everything to change the question, but that's a good way to see things.
Hi, it's May. Why rural is a bit of a difficult question for me because it's not as structured, as formalized as everyone else's. The ones who do healthcare, yes, that is part of rural, but I think it has a lot to do with my upbringing, my background. My parents are both doctors from Burma and they worked in rural villages in Burma. And I think the rural bug bit me in my first clinical rural rotation. And I wasn't sure why, but I had a deep sense of feeling and compassion and love for connection with the community. And I was very emotional. I cried a lot during my rotation. I cried with patients. I cried when I left. I cried, when I was happy. I cried when I was sad. I never quite understood. I think it probably clicked when I went to visit family in Burma, and we went to visit the small village that my parents opened a practice in, and just witnessing how much love that my parents had for that village, that community, and how much love the community had for them and our family, just because they served them so well and so openly and so lovingly. I think that's probably for me, like, I probably can't get away from it, so it might be the blood, but I really think that connection and that ability to feel is why I'm drawn to the role so strong.
Wonderful. Thank you, May. We do have now subscribed Bernhard, and then after Lunjil, Gamet, and then Ian. And we are going to the end, but it's been such a great conversation. I will just want, So not much going on Facebook, on YouTube. Usually, sometimes people watch and then comment after. But anyway, Bernhard.
I'm not sure whether May has spoken, but maybe she could speak now, or let me jump in quickly. I think the other area that is really amazing in rural is that the scale of things is in some ways much smaller. The teams are smaller and they're more connected. So, and that gives you so much more agency. So like I remember when the ARV rollout happened here in South Africa, there were in 2007, there were only about 5 sites in the country that were able to meet the targets that were supposed to be met in 2011. And all of those 5 sites were rural. And the reason for that was that they were smaller teams, they could work together, they could organize the system, they could get much quicker consensus about what needs to be done. And so that sort of agency, that sort of being able to fix things in the smaller teams is something that is really incredible in rural. It's much, much harder in cities where there are all these levels of bureaucracy and all sorts of people with very big egos, and you first have to take it to this committee and that committee and whatever. Like if you know the sister in the clinic and the sister knows the community health workers and you know the sisters at the other clinics, you can very quickly, like there's a small network of decision making that then allows the whole system to shift and implement strategies that are otherwise kind of much harder to implement. And I think that also links a little bit to what Victor was saying. Like for me, that was also really incredible. Like I could walk from a meeting with the traditional healers, go straight to theatre and teach a junior doctor how to do a cesarean section, to going to certain outpatients and listen to some amazing stories from the grannies. And, you know, it's like, that's just moving from one to the next very rapidly. It was really incredible.
Thank you, Bernhard. Do we have now Lunjil Gamet?
Okay, hi everyone. My name is Lungile Gamete, and so why rural for me is sure. So initially, you know, I've always wanted, like ever since starting my undergrad as a nurse. So I studied at an urban university at Wits, and you know, I've always wanted to go rural, but I think more for me it was more for the scenery, you know, like I used to travel to school every day from home. So just, you know, being stuck in traffic and just all the city hustle and bustle got to a point where I was just like, you know, no, actually I want to, you know, later on in my life when I'm advanced in my career, settle down in a rural placement or rural facility. And yeah, so it's always been a desire of mine, but not soon, not like in my early career years. But, you know, lo and behold, when I had to do my community service year, I was placed in a rural facility, rural primary healthcare facility, and shoo. Well, I was happy for the primary healthcare part, but was very concerned with, I've never, you know, I also, the only experience that I got working in a rural setting was, you know, in the Pillow Pepper healthcare train. And, you know, that was like, I think 2 weeks. It was an amazing experience, but, you know, I didn't feel like, you know, it was enough to prepare me for a whole year of placement at a rural facility. But anyway, I eventually went, and it was, okay, because it was primary healthcare, I really did enjoy, like even throughout my studies, I always gravitated towards PHC, you know, community development, you know, like the human, realizing all the other factors that influence health, and, you know, interacting with the community and speaking to, you know, the gogo mkhulu who would come to me beyond just collecting the treatment. But, you know, one thing that I did realize from, you know, the year that I did my community service at a rural facility was that there were so many challenges, you know, that were so frustrating. From, I think the one that takes the cup is the ambulance arriving late, and the time it would take patients to get to the hospital that would be most appropriate for referral purposes. And I think I got to a point where I was like, you know what, there's just so much to change, and the problem isn't really here within the four walls of the facility, but it's beyond, it's systemic, and I really want to do something about it. You know, I want to look beyond practicing within the walls, but you know, just look beyond and see what I can do. So, you know, finding myself where I am right now, which is not practicing physically, but, you know, still working in advocacy towards, you know, the betterment of rural healthcare services. You know, I can say I can't have imagined myself in a better position because of what I experienced. So that's my story. Thank you.
Thank you, Unji. I think I do share some stories very similar. Unfortunately, to be waiting ambulance and how hard it is to sometimes, you know, like the difficulties of the rural and the challenges, and also that if you, not always we can make the challenge like as an impulse. Sometimes it's very hard just to deal with this. But I think it's really, really important that you bring it to here. I will ask for Mercy. She has some comments on YouTube, and then after Mercy, Ian can talk straight after Mercy about his comments. Mercy first.
So I have first year medical student from Cape Town. Let's say, yes, from Cape Town. She's from Seleni, Nzazulu, I think. I don't know if I pronounced that right. Natal in South Africa. And she says that one of the reasons why she's considering rural is due to the stories that she's heard about doctors running away from rural. And she's asking herself why, because to her, those people really need help. And she has heard that most doctors complain about poor infrastructure in these settings, but then she still feels like there's something that she can do to change the situation rather than running away from it. So I think that is an awesome thing from a young and budding doctor to think about working in rural areas.
Thanks, Mercy. I just want to make 2 comments in reflection, and then I'm going to hand over to Roger to also make 1 or 2 comments in reflection. My first comment very much picks on what you've just been sharing, Mercy, which is around making a difference. We were at a meeting a number of years ago in the Northwest Province, and we had some number of people from community and different health professions and so on. And we were talking about going rural, and a clinical associate student stood up and he said, I'm not going to go back rural. I joined this program in order to get out of my town because nothing happens there. If you stay there, you make people pregnant. It's just a disaster. And we had a final year medical student who was also from a rural area in Northwest who stood up and challenged him, and she said to him, if you don't go back to your town to make a difference, it's always going to be like that. It'll only change if you will go back and make a difference. And so it's lovely to hear stories like from Vutlare and Lungi and others about wanting to go back and make a difference. And what I want to say to the students is that you've got incredible power. I don't think you realize the power. You think as faculty we have power, but actually you have much greater power. If you can challenge faculty to make sure they're admitting students from rural areas as a priority, and they are training people in rural areas as a priority, we can really make a difference, because it is difficult to go back alone. It is much easier if some of you go together and you support each other, then you can make that difference. The second reflection I want to make and say thank you to Maputi for her positive comments about what we've done at Ukwanda. I was recently at an AfriHealth, it's an Africa-wide organization seminar, and I was talking about rural, and somebody else from South Africa in the chat said, oh, but you're from the Western Cape, that's not really rural, why are you speaking? And it actually took someone from Uganda to say, well, I've been to some of those places in the Western Cape and they're more rural than anywhere else. But the point I'm making, it shouldn't be a hierarchy. We shouldn't be about competing. No, you're more rural than I'm rural. You know, you have it tougher than I do. Throughout the world, wherever we go, we find that the issues are the same in terms of access to care. That is the real #1 rural issue. And we need to be supporting and helping each other and doing everything we can to work together to make a difference. we shouldn't be trying to compete or do better than each other. It's about working together to make a difference. Thank you. And over to you, Roger.
Yes, well, thank you, Ian. And I think you're picking up on the theme of the commitment to make a difference, to improve the health of the people living in remote and rural communities. I mean, that's, I think, what's it's the central driving force of rural health and rural practice, and really the major motivation that we have. And I think to really make a difference, we need to have more rural doctors. We need to inspire more young people to see how rewarding and satisfying, as we've heard from the speakers today, rural practice is, and really to put together the connections of a career pathway, facilitate a career pathway that starts with encouraging young people in the rural community to see a future for themselves, which might include healthcare and studying medicine to become doctors. And then, as you said, Ian, for the medical schools to have an admissions process that favours applicants who come from rural areas. And then as medical students, the opportunity to really experience the opportunities of rural practice. If you don't see it, you can't be it. And so it's important for students to be learning in the rural setting. And I think there's good evidence now that a true immersive experience, living and learning in a rural community, is rewarding and satisfying as a student. As we heard, you're not just an observer, but you're really a participant, and learn so much more than if you're in a big city teaching hospital. So it's great for the students, and it's inspiring. It's when the students really learn to focus on improving the health of the people that they have the privilege to serve. And then after graduation, as junior doctors, actually learning, being based in rural communities, and maybe having to do a rotation to the city, but based in the rural communities as a stepping stone to postgraduate training, vocational training in rural family medicine. So that's the pathway. And then in practice, so that there are more of us, and we're working together as a team to improve the health of people living in remote and rural communities. And for those of us in practice, it's so important to have organizations, rural doctor organizations like Rudasa, that connect rural practitioners, that bring students and junior doctors to conferences like this one. And so it's this kind of discussion that we've had today that I personally find so exciting and energizing. And I think those of us who've been around for a while, it gives us that renewed energy, and the students and the junior doctors can see a future for themselves, inspired by experienced rural doctors like Victor and the others that we've heard about how wonderful it is to be a rural practitioner. So I think this has been a fantastic discussion. Thank you, Mayara, for your great job as moderator and chair, and thank you all for your contribution to this really fantastic Rural Family Medicine Cafe.
Thank you, Roger. Thank you, Ian, and all. We are moving to the end. It's always like a pleasure to run a rural cafe. It's very special to run rural cafe in South Africa. We have asked for a little bit of some 10 minutes around more for us to close. I think at the venue, Lange wants to talk, and maybe May. I'm not sure if you want to talk or not, but feel welcome to talk. And but it's always good that we feel that we are not alone. I just want to resonate on that we are a team, that we can discuss cases with our peers in all around the world. And this is like what sometimes I receive like some message from Nepal or from India, from places that I have been, and then people want to discuss a case, and then sometimes it can bring some different perspective. And this is wonderful. Adam and I, we were discussing some things about the practice before the conference. And this was really interesting for myself to understand where he works and maybe he could understand a little bit of where I am working. So we are not alone, and the students are not alone. We now have rural seeds, we have created a community, we have the African ambassadors. You're not alone, and we need to work together. The only way that we transpass this crisis, all the crises, climate crisis, economic crisis, and everything, environmental crisis, the lack of rural access crisis, it is together. It's not alone. So that we feel that we can go together. So I just give the word to Lanji, and I'm not sure if you may want to talk or not, but feel free. And then if anyone wants to say any final comments, it would be really great. Lanji.
Thank you. So just as a final comment, I want to remind healthcare professionals how much power they hold in their hands. So when I had recently qualified, I had a major issue with being put on a pedestal in my community until I realized just how much power that had in me inspiring the young girls in the community, inspiring young boys. There's actually, I started inviting young school kids to the hospital for their holidays when they're in grade 11, just so they can experience a working environment and make a decision whether they want to join healthcare, a healthcare discipline. So one of the boys that came, unfortunately, wasn't accepted into medicine, but he's now got his certification as a pilot. So, you know, when you go back, especially I'm saying this to the students, when you go back to rural communities, there's just so much scope for you to do beyond medicine, beyond the challenges that you see in patient care, but in actually bringing positive impacts in the communities that you work with. And it goes way beyond that. It goes into empowering women, putting together some groups or community projects, whatever you may feel you have a passion for. So yeah, allow people to put you on a pedestal, but use that to actually then uplift the community to be at your level on that pedestal with you. Thank you. Oh, okay. It sounds like I have to close the session as well. Yeah. Okay, so thank you everyone for joining this session. And thank you for the online participants as well, the comments. It's been such a great session of reflections and inspiration as well. Thank you.
Thank you. We gotta, like Steph said, that we have like 10 minutes, 5 minutes more. I would just really thank you. We have Joseph from Spain now mentioning us on Twitter. This conversation, it doesn't finish here. People will watch us on YouTube, will comment on Twitter and Facebook, and we will keep thinking about why rural. And it's very inspirational to feel all these stories. Thank you so much. And I hope you have your cup of coffee and we keep discussing rural worldwide and also locally. Really thank you to the ambassadors, Mustafa, Celestine, and Mercy, which were working on our social media. And it was a really, really cool moment. Thank you. And I do really hope I can visit South Africa and we can keep the discussion as well for in person. I was commenting with Bernhard that it's much cooler when we see each other in person.
Thanks.
Bye-bye.
Bye all.
Thank you so much. Bye.
Bye-bye.
Thank you. Bye-bye.
Bye, everyone.
Bye-bye. Thank you, everyone. Bye-bye.
Bye-bye.
Just to ask at the venue to stop the transmission on YouTube, please.
Cheers.
Cheers.
chairs. What are
Yeah, but
chairs?
just the chairs here.
Let's leave the chairs alone.
The chairs are already here.